Okay. So good morning, everybody. I think my task here in the next minutes is to talk about what to do with these patients with high rate episodes that are detected with devices. And I should tell you that some time ago when we started a trial, and Paulus asked it to be part of the trial, I said, well, why do we need this trial? I mean, if you see atrial fibrillation in the device, you just give anticoagulation and that's it. But apparently it's a bit more complex than that. And I had to look at it and it really, the first definition is that it's even a problem, the definition. You say atrial high rate around 190 beats detected by an implantable electronic device. It's not exact, so depending a little bit on the different studies have taken different definitions, but more or less it's like this. Also, the capability of the different vendors, it's a bit different. So, and in different studies, the cutoff has been taken in different cutoffs, but more or less it's what to do with this kind of patients where the device told you that you have found a high rate episode. The first thing, of course, we have to make sure that there's really not really an electromagnetic interference. And what's the real life? The real life is that you have a pacemaker clinic that it's run by not by a cardiologist, it's run by a nurse or a technician, and what to do. So in the past what we did, okay, let's if the technician saw this kind of thing, he sent this to his cardiologist. But of course the cardiologist has not the device in front, he's not interrogating the device. And then the cardiologist received a patient that was sent from our technician saying, this patient has atrial high rates episode. So, I mean, really it's becoming a more and more common problem here, and because of this approach in this kind of patients. Of course, we have myopotentials, we have a lot of things, but well, let's assume that these patients are seen in a specialized unit that it's really able to identify who really has episodes of high rate that correspond to this kind of recording. Okay, what to do with him? Of course, we are creating a new disease, because if we have the traditional way to detect atrial fibrillation, whether we do a Holter, a loop recorder, we are increasing our capabilities. But nowadays we have this kind of continuous recording. So we are finding things that we have never seen before. And that's the difficulty here. And in fact, more or less it's considered about 75% of patients who are having this kind of atrial high rate episodes will not develop in short-term atrial fibrillation. So do they have an increased thromboembolic risk? Are short runs equally implying a higher rate of stroke? Well, it seems that they do. I mean, there's some meta-analysis showing that when you have this kind of episodes, you really have higher risk of thromboembolic events. So at least this kind of link is there. And it has been shown also that in most of the studies, the different studies show that it also is related to the chats. So it's not only having the high atrial rate episodes, but also it's when you have higher chats, you have higher chances. So still, we are starting to stratify a little bit more this finding. But also there's another very important point that it's really not clear. It's what is the duration? When should we start doing anticoagulation? And it seems that, for instance, you have more than 24 hours of high rate, that would be more than 24 hours, something like atrial fibrillation, your risk is clearly increased. But when you are dealing with between 6 minutes and 24 hours, is this equivalent of what we call atrial fibrillation? In fact, it seems in different studies that there's a kind of a relation. So the longer the duration of the episode, that's for instance this from Isabel, more than 24 hours, you have higher chances of suffering events or embolic events as compared to less, for instance, from 6 minutes to 6 hours. So we are seeing here a relation with duration. We are seeing a relation with TRADS-BASC, of course. So we are starting to put some classification here to be more precise in who needs and who doesn't need this. No? There are other studies. This, for instance, atrial high rate episodes have been related also to silent ischemic brain lesions detected by in this patient. No? So in this study, this is one of the markers of risk. No? So even in asymptomatic episodes of silent ischemic brain lesions are related to that. So they have importance, but the problem is that we know they are important, but we do not know exactly when to start anticoagulation, because anticoagulation in itself has also some risks. And that's why we need this NOAA trial, and we need the Artesia trial. Those two trials are ongoing. We are participating in NOAA, that is doing very well, I think, and thanks to Paulus and his persistence, and so he's been able to put these trials on board. And for instance, we talk about, they are very similar with the slight differences. Perhaps the major difference in the Artesia, apart from being a bit more strict in the criteria for risk, it also that I think they are comparing also placebo, aspirin or active apixaban. So they are receiving something in each group, as opposed to the NOAA, where the patients are randomized to edoxaban or usual care with no anticoagulation. You can receive either aspirin or placebo, but it is open. No? So more or less the definitions are similar in the sense that it's more than 170, more than 6 minutes, more than 65-year-old plus one additional risk factor. What about the recommendations that we have until we reach this the results of these studies? Well, nowadays this paper that was published in 2007 as a position paper recommends that in patients with CHA2DS more than 2, with more than 5 hours of duration, the recommendation is to start anticoagulation. Whereas when you do not have such a high CHA2DS, then it's really not so recommended, no? But the first thing is that they require a long-standing high-rate episode of at least 6 hours. What about the American guidelines? It's very open, so they say that they should from further evaluation to document the relevant AF, because if you just have these electronic devices, high-rate episodes, it's not so clear whether you have or you do not have to. So it's really an open issue that it's very important because it's here and we have to face it. And what people are doing now, I mean, this is a result of a survey, and they found that among European cardiologists, they pass several interviews and some questionnaires, and they see that the longer the duration, of course, the higher the chances that the doctors go for anticoagulation. No? So it is more, if you have more than 24 hours, 100% of the physicians would anticoagulate these patients regarding different risk factors, so A, B, C, D. So in CHA2DS, patient A would be CHA2DS 2, 3, no? And worst scenario would be patient D with CHA2DS 4 more than 2. So shorter episodes is the ones that are really very difficult to decide. What do you do with a patient with 6 minutes AFib in a pacemaker? And this is really an open issue. And so I think in conclusion that the detection of these atrial high rate episodes in implanted devices has created a new clinical scenario that we have never faced before. And we cannot apply simply the rules that we had before in other conditions. And we are fortunate enough that we have a couple of ongoing trials that probably may clarify our conduct in the coming years. So thank you very much for your attention.